Hi guys, my name is Brennan Geist. I am a student physical therapist and I'll be making a video today on some special tests for the ankle and foot. This is my brother Josh. This is Carmen. They're going to be helping me out in today's video. I wanted to go ahead and say in the beginning, so I am doing all of these tests on a single or the involved side. For the purposes of a clinic or whenever you're practicing, I suggest that you're going to go ahead and do both sides, the uninvolved first and then the involved side, so you're not getting some false positives and making sure that you are getting the correct information that you're looking for. So, if you are going to be a good therapist, you need to do the uninvolved first. Josh is going to be modeling Advent Health water from now on, and I hope you guys enjoy the video. Alright, so today we're going to be going over a cotton or a clump test. This is going to be looking for a Mortise or a syndesmosis instability. So what we're going to do in this case is have our patient go ahead and straighten your leg out for me. Let it relax. And what I'm going to be doing is I'm going to be stabilizing at the tibiofibular joint. From here, I'm going to be taking the calcaneus and I'm going to be applying a lateral pressure. And what I'm looking for here is either A, more than 3 to 5 millimeters of translation, or B, a kind of like a clunk when I'm going into that motion. And that's going to be considered a positive test. Alright, so similar to the cotton test, we have another test, the medial subtalar glide test, and this is also going to be looking for that Mortise or that syndesmosis instability. So very similarly, we're going to be stabilizing at the tib joint, giving pressure here, and then what we're going to do instead of going laterally, this time we're going to be going medially, giving that overpressure. And similarly, we're going to be looking for that 3 to 5 millimeters of translation or looking for a clunk when we're going through that motion, and that would be considered a positive test. Alright, so today we're going to be going over the Kleiger test or the external rotation test. Again, this is going to be testing for the Mortise or syndesmosis instability. So we're going to be again giving that stabilization at the tib joint here. And then from here, what we're going to do is we're going to use the calcaneus, and we're going to use the calcaneus to externally rotate the patient. And what we're looking for is a reproduction of their symptoms, a reproduction of their pain. If you do get that reproduction, that's going to be considered a positive test for that instability. Alright, so today we're going to be going over the fibular translation test. So again, this is going to be looking for if we think that they have a high ankle sprain, a Mortise, or a syndesmosis issue. So what we can do is, optionally, we can stabilize at the tibia here first. We're going to have our patient inside lying. We can come to the lateral malleolus. We're going to come just a little bit proximal of that, find our fibula, and from here we can apply a posterior translation force. We're looking for a reproduction of their pain or their symptoms. And then similarly, we can wrap around the posterior portion, and now we can give it an anterior force. And again, a positive finding is going to be that reproduction of symptoms. And if you have a bigger patient, you are able to flip around and do a push instead of a pull if you're having an issue actually giving that pull. Alright, so today we're going to be going over the squeeze test. So again, this is going to be looking for a high ankle sprain, so looking for a problem with the syndesmosis. So what we're going to be doing here is we're going to have our patient starting in supine. We're going to have them on their back. What I'm going to do here is straighten my patient's leg out, and I'm going to come to the distal third of the tibia and fibula, so coming about right here. And what I'm going to do is I'm going to make sure I have a hold of the tibia and the fibula. And I'm going to give a good squeeze here and look for any reproduction of pain or symptoms for my patient. So in this case, he didn't have any reproduction of pain or symptoms. If they are having that pain that's still coming down here, where they're having that complaint of pain, then that's telling you that there is a problem with the syndesmosis because it's sending the forces down. So you can be pretty sure that the problem is coming from that syndesmosis. So that will be a positive test with the reproduction of pain. Alright, so Now we're going to be going over a heel thump test. So again, this is going to be a test for a high ankle sprain. This is also a test for a tibial stress fracture. So if you are suspecting that the patient might have a tibial stress fracture, you might want to kind of rule this out if you're afraid of that, because then you're going to be getting kind of a false positive because the pain may be coming more to the tibia rather than what you're looking for here, which is going to be that high ankle sprain with the syndesmosis or the mortise. So we're going to have our patient's leg hanging off of the bed. We're going to have them in a neutral position. And all we're going to do is give them a little bit of stabilization here at the tibia. I'm going to take my palm and I'm going to give them a good thump onto their heel. So patient, on the count of three, I'm going to give you a thump. 1, 2, and 3. And if I'm going to get a reproduction of that pain that they're complaining of here on the ankle, then that's going to be considered a positive test. Alright, so we're going to be going over the anterior drawer test today. So this is going to be looking for more of a lateral ankle sprain. So in the case that we suspect that, what we can do is have our patient lying in supine, like here. What I'm going to do is I'm going to give some stabilization at the tibia. I'm going to come around to the posterior aspect of the calcaneus, and I'm going to be applying that anterior translation. So I'm going to be pulling up, and what I'm looking for is either excessive motion, excessive laxity, or a kind of a clunk that's going to come with that. It is important to compare to the uninvolved side, especially in this case, because we have some people that are just going to have overall systemic laxity or laxity of that ligament specific, but that anterior translation that's excessive is going to be that positive sign. And that's going to be more indicative of a anterior talofibular ligament rather than something like a calcaneofibular ligament. Alright, so today we're going to be going over the Taylor tilt test. So this is going to be again testing for a more of a lateral ligament sprain. And in this case, it's going to be testing both for the calcaneofibular ligament as well as the ATFO. So what we're going to be doing is having our patient start in side lying as such. And what I'm going to do here is I'm going to have them resting their leg kind of on top of this other leg so that they're comfy. And now I'm going to be coming around from the posterior, around the talus, coming around to the calcaneus, and then coming around the anterior portion, kind of above and in front of that lateral malleolus, again coming down onto the talus and calcaneus. And what I'm going to be doing from here is trying to get a little bit of inversion coming from their foot as I push down. So I'm going to push, kind of bring it back, go again. And what I'm looking for here is either a reproduction of the patient's pain. We may see excessive laxity as compared to the other side, or we may actually get a clunk as compared to the other side. And any of those are going to be considered a positive test. Alright, so next we're going to be going over the Homans test. So if you are suspecting either a vascular issue or a DVT, this is going to be a test that we can use looking for those signs that are going to give us a positive. So what we're going to be doing here is actually just giving this calf a good squeeze. So I'm going to come here, I'm going to squeeze the calf, and kind of work my way around to the different areas. And having a reproduction of that pain is going to be a positive. However, this could also just be like calf soreness or a calf tear. So one thing we can do to sensitize it a little bit further is I'm going to go ahead and bring him into a little bit of dorsiflexion here. And similarly from here, I'm going to be giving that calf squeeze and looking for a reproduction of pain here as well. So if they do have that reproduction, that is going to be considered a positive finding, and that may be something that will make you suspicious of a DVT or vascular issue. However, you should also go ahead and combine this with something like the Wells DVT guidelines to help further triangulate what you're thinking. Alright, so again, another special test that we can do when we're looking at vascular issue is going to be called the Berger's test. So with this, what we're going to be doing is taking our patient's leg, we're going to go ahead and elevate it. And then once we have it elevated, we're actually going to keep it here for about 3 minutes. And as we're doing that, we're going to be looking for discoloration or a loss of color, I should say, some blanching throughout the foot and the lower extremity. You also may see that the veins are going to start to drop, disappear. So once we've had the patient up for about 3 minutes, if we're seeing that blanching, then what we're going to do is go ahead and drop the patient's leg off of the side of the plinth here. And we're going to be watching for a return of color. What we want to see is a return of that color within about 30 seconds or so. And if we don't see that, if it takes, let's say, more than a minute, that is going to be kind of significant of a vascular issue, so that would be a positive test. All right, so today we're going to be going over the Thompson and the Maddles test. Both of these are going to be tests for the Achilles tendon. So I'm just going to go ahead and roll your leg up a little bit here more, sir. All right, so we're going to have our patient starting in prone. And what we're going to be doing is actually just giving a squeeze to the back of the calf here. And what we're going to be looking for as I give that squeeze is the patient's foot should go into a bit of plantar flexion as I give that squeeze. And that's going to be a sign that the Achilles is still intact. So I'm going to go ahead and squeeze. Boop, you get a little bit of plantar flexion right there. If they don't have that plantar flexion happen, then that is going to be a positive, and that's going to be indicative that there is a problem with the Achilles tendon. All right, so today we're going to be going over Maddles. So again, this is going to be a test for the Achilles tendon. What I'm going to be doing here is I'm going to have Josh, I'm just going to ask him to flex his knee, bring his foot into the air. I'm not going to say anything else. What I'm looking for here is as he comes up, I'm looking at the angle of his dorsiflexion and or plantar flexion as he's coming up. So as he came up here, I didn't see any change that was going throughout his dorsiflexion or plantar flexion. That's a good thing. In the case that this is a positive, what I would see is as I asked him to bring up his foot, so go ahead and lift your foot slowly for me, I would see that he would actually start going into more and more dorsiflexion as we were coming up into this position because that Achilles tendon isn't actually giving any stress. It's not working. So if you see that that dorsiflexion is going more as you're coming up, then that's going to be a positive test. Okay, so next we're going to be going over the Royal Hospital test. So instead of looking for a rupture this time, we'll be looking for a tendinopathy. So what I'm going to do is have my patient laying in prone as such. What I'm going to do is give a pinch onto the Achilles here. Oh. And if my patient has a pain that is coming along when I am giving that, what I'm going to do next is I'm actually going to go ahead and have him go into active dorsiflexion. So patient, could you push your foot into my fingers here? Pull up, up, up. Good. And then once he's done that, I'm going to go ahead and pinch again. And in the case that either the pain completely went away or there is significantly less pain, that is going to be considered a positive test, so that is going to be positive for a tendinopathy. All right, so we're going to be going over Tinel's test. So this is going to be testing if we are suspecting some nerve issues that are going on in the foot. We have two main areas that we can test with the Tinel's test. So I'm going to have the patient in supine as such. I am going to come down to where our deep fibular nerve is going to be, and what I'm going to do is just give them a good tap. And if the patient reports that they are having a reproduction of their symptoms, maybe having that numbness and tingling coming down to their foot, that is going to be a positive test. And similarly, also part of the Tinel's, we can come down to our posterior tibial nerve, and then what we're going to do here is again give a good tap. And again, we're looking for that reproduction of pain, reproduction of symptoms that they're having, that numbness or tingling. And if you get a reproduction on either of those, that is going to be a positive Tinel's test. All right, so in the case that we are suspicious of a neuroma, a test that we can do is called the Morton's test. So what we're going to do is we're actually just going to come around the metatarsals. And all we're going to do is give a good squeeze here. So I'm going to squeeze in. And in the event that my patient has a reproduction of their symptoms, so maybe they're having that numbness and tingling, that is going to be considered a positive test, and that would be indicative of a neuroma. Okay, so we're going to be going over Weiss's line. So this is something that, let's say that a patient has a pes planus. We can kind of use this to rule in or out whether we think that this is going to be a functional or a anatomical issue, and functional or anatomical pes planus. So for Weiss's line, what I'm going to do is I'm going to come to the medial malleolus. I'm going to come down to the base of the first, and then I'm going to come to the navicular tuberosity. So what we want to see is that the patient has a relatively linear line here. So the navicular tuberosity should be falling in line with the base of the first and the medial malleolus. Josh, in this case, does look good. In the case that a patient had a significantly dropped navicular, that is going to be kind of a sign that they may be actually having a anatomical issue with their pes planus. So an anatomical pes planus. In the opposite event, let's say that, like Josh has, he has a very good Weiss's line here, but then when we go down into weight bearing and I measure again, and I see that his navicular drops more than 10 millimeters or 1 centimeter, then that is going to be kind of indicative that he may be having a functional pes planus. So he's actually having the navicular drop, but only on the functional aspect, such as weight bearing. So that's going to be how you're going to find Weiss's line and kind of what you can use it to use for clinical decision making. Okay, so today we're going to be going over the functional hallux limitus test. So what we are looking for here is if the first ray is going to be going into some plantar flexion when I bring the big toe into some dorsiflexion, kind of as a compensatory mechanism. So what I'm going to do first is I'm going to go ahead and find subtalar neutral. Can I have you scoot down just a little bit for me? Good. Go ahead, straighten this leg for me. Good. So I'm going to come around to the talus, and I'm going to move him around, find where his subtalar neutral is. I'm going to give a slide over pressure here. And then from here, I'm going to go ahead and, like I said before, we're going to apply a dorsiflexion to his big toe. And what we're looking for is if this first ray is coming into some plantar flexion. So in this case, he is not going into any excessive plantar flexion, so that is going to be a negative test. But if we did see that that first ray was coming down more into plantar flexion, that would be a positive, and that is a functional hallucis limitus. All right, so next, something that we can do if we're becoming suspicious of a plantar fasciitis is going to be the windlass test. So what we're going to do here is, normally I would have my patient do it on a step. I'm just going to go ahead and use the plinth for the purposes of today's video. However, we are going to, on the step, have our patient bring their foot so that their foot is still staying in contact with the step. However, their toes are going to be coming off. So I'm going to have the patient go ahead and relax your leg, relax your foot for me. And all I'm going to be doing is applying a dorsiflexion or extension to the big toe. Giving a nice little stretch here. Good. And my patient has no pain as I go throughout his full dorsiflexion or extension of the toe. So that is going to be a negative. In the case that they do have a reproduction of their symptoms, so they're having that pain that's going through the bottom of their foot, then that is going to be considered a positive windlass test, and that may be a sign of a plantar fasciitis.